All right, well, I think with that, we can go ahead and get started. And thank you everyone for tuning in to Grand Rounds this evening. And you might have or hopefully have seen some related news and social media announcements in the past several months. And so I wanted to take this opportunity just to talk to you a little bit more about radiofrequency ablation of the thyroid. This is a new and really exciting procedure that Dr. Orloff and myself have recently started offering at Stanford. And after some, of course, COVID-related delays and negotiation about how to introduce this into our practice in the Cancer Center, I am happy to say we are now ready for prime time. So thyroid patients are a unique group. There's a mix of benign and malignant pathologies, and those with cancer diagnoses still do and expect to live long and healthy lives after surgery. And this is a predominantly female cohort, and many patients are very young. So all of this is to say that more so than some of the other types of surgeries in our specialty, there appropriately has been a larger focus on aesthetics. And we know from multiple studies that presence and appearance of the scar does have a significant impact on quality of life and self-perception of patients who've had thyroid surgery. The specific study mentions that 3/4 of patients would have opted for an approach that instead left an extra cervical scar had that been offered to them at the time of surgery. And to that end, we have gone to great lengths to develop tools and techniques that allow thyroid surgery to be performed from every which angle other than the central neck. And this has included both robotic and endoscopic techniques and facilitated thyroidectomy through retroauricular incisions, facelift incisions, breast and axillary incisions, and what has now become the most widely adopted favorite, transoral mucosal incisions. But it's also not just about the scar. Decision-making in thyroid surgery is complex, and we know that patients delay or avoid intervention in large part because of concern about the risks of surgery and general anesthesia, and for the potential need for thyroid hormone replacement. And even if we just perform a lobectomy, this is still on the order of 15 to 20% of patients who may need thyroid hormone postoperatively. So we've certainly all seen those patients who've waited years or decades and now need a bigger surgery with inherently greater risk to solve their substernal thyroid nodule or their compressive goiter. So this is where thyroid ablation fulfills the need for an option that can preserve normal thyroid parenchyma and allow a non-surgical approach. And you'll see shortly that this has been a long time in the making, requiring adaptation of equipment specifically for this purpose, as well as the establishment of efficacy and safety relative to a traditional surgical approach. So this is the full spectrum of ablative options that have been and still are used in thyroid applications. Alcohol is really the original ablative tool. It's been used for decades, though we've come to realize that it's not as good for the solid component of a nodule, and can also take several rounds of ablation to result in the desired reduction. The laser is an ND-YAG source with an optical fiber, so this is another type of thermal ablation, and it does have a safety and cost profile that's pretty similar to radiofrequency ablation. But the head-to-head studies have shown that it may be slightly less effective, but it is still the most commonly used ablative technique other than RFA. Microwave ablation doesn't have a lot of high-quality evidence, and the efficacy does seem to be less than laser or radiofrequency ablation. It also has the least control of all of the applied energies, which so far has translated into the greatest complication rate. And then high frequency ultrasound, or HIFU, relies on heat generation by the conversion of acoustic energy. And so with the help of the computerized mapping, this creates a target treatment area, the safety margins around the critical structures, before the machine delivers the ultrasound beam. So there's actually no insertion of any needles or probes. But HIFU really suffers from a lack of data and no direct comparisons with the other techniques listed here. There's also much more of a learning curve, so the reported size reduction has been exceptionally variable so far. And finally, this is the most expensive of any of these pieces of equipment. It's about $250,000 to purchase one. So of these, radio frequency ablation has really emerged as the most cost-effective and safest technology that's already very familiar to providers that are doing their own ultrasound and ultrasound-guided procedures and biopsies. And although it's been a very recent development that thyroid RFA has been available in the US, our colleagues in Europe and South America and Asia have been performing RFA since the early 2000s, and we owe a great deal of credit to them for bringing this to the forefront of our attention and providing a lot of the data that has led to growing international enthusiasm and adoption. The earliest and certainly most prolific pioneers were in Korea, and you can see on this timeline that their first publication on a cohort of patients with benign nodules was published now almost 15 years ago in 2006. They were also the first to incorporate this technique into any existing recommendations. And then the Korean Society of Thyroid Radiology released the first set of RFA-specific official guidelines in 2012. Italy and the UK were not far behind in their own recommendation statements. And it wasn't until 2016 that American guidelines even gave RFA a brief mention. And this was only a year before the Korean Society of Thyroid Radiology was already on their second version. In 2019, the FDA finally approved radio frequency for devices intended for use in the thyroid. And meanwhile, the European Thyroid Association has just come out with its own clinical practice guideline. So the US has fortunately finally jumped on the bandwagon and will almost certainly have its own set of guidelines in the not too distant future. Radiofrequency ablation as a technology is certainly not new and actually had its beginnings in an application that bears relevance to us as otolaryngology providers in treating trigeminal neuralgia, for which to this day it actually remains still a preferred option for this condition. And then in the 1950s, the first commercially available device was manufactured, then used throughout the 70s and the 80s, mostly for cardiac and neuropathic conditions. And then finally, FDA approval for soft tissue destruction came in 1997. And this brought on a wave of incredibly diverse applications for radiofrequency. And today, still the biggest market is in oncologic or soft tissue ablation. RFA is a well-described primary or adjuvant treatment modality for high-risk surgical patients that have, hepatocellular carcinoma, liver mets, primary lung tumors, renal cell carcinomas, and bony mets and osteomas. And interventional cardiology has the next largest piece of the pie, where it's used to destroy abnormal conduction pathways that lead to arrhythmias, which has essentially replaced what would otherwise be a very risky open heart surgery and or a lifelong need for medication. And as I mentioned just a moment ago, it remains a preferred option for nerve pain. Many surgeons in our own department are familiar with radiofrequency ablation for turbinate tongue, soft palate reductions. Barrett's esophagus and endometriosis can be treated with RF, and the list really goes on. So it's actually quite difficult to find a specialty that is completely untouched by radiofrequency devices. So how does it work? Well, radiofrequency is an alternating electric current that oscillates at a high frequency range. And as the current passes through resistive tissue or the patient, the ions become agitated and they generate a frictional heat. So this is a thermally based tissue destruction, and that causes protein denaturation and loss of intracellular fluid. Achieving and maintaining the right temperature during radiofrequency ablation is therefore necessary for coagulative necrosis to occur, which is the goal for adequate tissue ablation. So anything below 45 degrees Celsius, the tissue damage will be reversible. So the goal is really to reach and stay between about 50 and 100 degrees Celsius throughout. At this level, the cytotoxicity is either instant or within about 4 to 6 minutes. But if the temperature goes above 100 degrees Celsius, then that actually creates a char from carbonization around the electrode tip that impedes further ablation. These are the basic components of the circuit. And this is a monopolar system, so the setup is almost the same as using the Bovie in the operating room. So the generator produces the power gets delivered to the electrode. Because of the small size of the tip, a really high degree of energy concentrates around it. And then that energy has to be dissipated by a much larger surface area of the grounding pads. The strongest recommendation and probably the best place to start, and where we started in incorporating this into our practice, is for benign thyroid nodules, preferably ones that are causing symptomatic and or cosmetic concerns. And this provides a really attractive alternative to surgery for a patient population who might otherwise be unmotivated or hesitant to pursue treatment until absolutely necessary. And then also for those patients with functional thyroid nodules that are contributing to hyperthyroidism, RFA can resolve or at the very least improve the hormonal imbalance in the vast majority of cases. RFA can also be a good option for patients with recurrent cancers, particularly for those who have already had multiple operations, might be at high risk for general anesthesia, or who just refuse surgery. So a similar instance to when we might use percutaneous ethanol ablation currently. And the treatment intent can be palliative just for symptomatic relief, or might be curative if the disease burden is limited to the neck and is low volume. There have also been case reports using this technology, again, more for symptomatic improvement in patients presenting with unresectable or very aggressive cancers. So for example, in anaplastic thyroid cancer or in advanced medullary thyroid carcinoma, but the tumor and symptom response is so variable, it's not currently recommended, and there's also some concern about tumor seeding from the probe. Papillary microcarcinoma gets a special mention here, since it sort of seems to be emerging as the newest hot topic in the RFA world. You know, we know that papillary microcarcinoma has at least partially contributed to the really significant increase in incidence of thyroid cancer that we've seen in the last 30 years or so. And there's been a wealth of recent information from China, Korea, Italy about the efficacy of RFA that shows really excellent rates of local regional control and even tumor disappearance in this space. And these two studies here are the largest, both of which show over 90% of treated nodules disappeared completely during the follow-up period. And I was actually just reading another article today in Thyroid that showed that 98% of patients treated with RFA for microcarcinomas remain free of radiographic disease at the 5-year mark post-procedure. So although we don't currently have guidelines on indications for RFA in treating primary malignancies, it's probably not too far down the line. Indeterminate nodules represent a bit of a knowledge gap in radiofrequency ablation. The limited data that we do have is sort of mixed. And this first study from 2015 showed that in 2 of 6 treated nodules that had originally been interpreted as Bethesda 3 or atypia of undetermined significance on FNA continued to grow and ultimately had to be surgically removed. And then on the final pathology, both were diagnosed as a minimally invasive follicular thyroid carcinoma. The second study is of 10 Bethesda 4 nodules, which are follicular lesions of undetermined significance. And these were effectively treated without regrowth over 5 years of follow-up. But I think the caveat here is that they all started quite small, between 1 and 2 centimeters, which probably means they were able to be more completely ablated. And so in general, owing to the limited and inconsistent evidence of treatment benefit, RFA is not currently recommended for indeterminate nodules, especially as it could delay a necessary surgery for a malignancy that may not be responsive. So who's the most ideal candidate? Well, it's someone with a benign thyroid nodule that's causing compressive or symptomatic cosmetic concerns. And you do want a reasonably sized target because the probe induces tissue damage a few millimeters beyond the tip. So 2 centimeters is sort of the published minimum. There's no definitive maximum, but the bigger the nodule, the more likely you are to need more than one session. And location is really important to consider. You do want to be able to safely ablate the entirety of the nodule for the best result. So those patients that have a big mediastinal component that you can't really see on ultrasound, or that lie in the tracheoesophageal groove or more posterior to the trachea, you have to leave quite a significant remnant, and so they may have regrowth and therefore need for additional treatment. Composition matters as well. So RFA is best for the solid or mostly solid nodules, though we do know that many benign nodules have a considerable cystic component. So sometimes we might need to combine radiofrequency with alcohol ablation. And then it's not mentioned here, but nodules that have a lot of calcification in them are also not ideal. They present some technical difficulty just in passing the probe through the tissue. And this ideal candidate does potentially represent a significant portion of the population. There's a huge range, but we can estimate from national population data that thyroid nodules are detectable in about 50% of adults, and the overwhelming majority of these, upwards of 90%, are benign. And most will stay the same size, but 15 to 20% will show significant growth over time, and these are the ones that may become problematic. And the majority of thyroid surgery that's performed in the US is also for benign disease. So this study on the right from 2010, it used the nationwide inpatient sample. And the point of the study was to look at surgeon volume and clinical outcomes, but just in the descriptive statistics identified that over 60% of the thyroid surgery had been performed for benign pathology. Now, we don't know what the preoperative biopsy showed or what other patient or thyroid related factors contributed to the surgical decision. But if we use this as a rough proportion and then consider a conservative estimate of about 150,000 thyroid surgeries performed annually in the US, that comes to about 90,000 surgeries that are done for benign nodules. And again, this is a very approximate number, but just intended to highlight the scope of the potential impact for this kind of therapeutic alternative. And not to mention all those patients we alluded to earlier who have benign thyroid nodules and prefer not to intervene on them. So for those patients in the position of needing or perhaps avoiding surgery, ablation does offer a number of advantages. It's a minimally invasive approach, so it doesn't require an incision. It's done outpatient. In fact, we do it in the clinic where we do our routine ultrasounds. And there's no need for general anesthesia, so patients can return to work and activities the next day. It's very safe. We'll talk in a bit more detail about this later on, but the risk of complication is analogous to, if not less than, surgery. And really the most significant difference, which we've touched on, is the almost certain preservation of thyroid function and therefore avoidance of lifelong hormone replacement. There are a few aspects of this kind of treatment to consider and things that we discuss with patients ahead of time, to make sure that this is the right choice for them. While the nodule size is significantly reduced, it doesn't go away completely, which could be sort of mentally challenging or even unacceptable for certain patients. There's the possibility of regrowth months to years after treatment that could require another ablation or a surgery. And for these reasons, surveillance with ultrasound also remains necessary. It's usually more frequent in the months immediately after treatment, just to confirm that the appropriate response is happening, but can be spaced out to annually or even less often once the size stabilizes. And finally, cost does factor into the decision as well. And though the overall expense of RFA is so much less than a surgery that requires OR time, anesthesia, maybe an admission. Insurance companies, not too surprisingly, lag behind the technology, and so the coverage at this point is a little unpredictable. Okay, so switching gears a little bit. This now seems like a lifetime ago, but actually it was just last fall that Dr. Orloff and then I had the opportunity to travel to Brazil to learn how to perform thyroid radiofrequency ablation from the 3 otolaryngologists pictured on the right here, who have been performing this procedure for over 5 years at this point, and pre-COVID had been very gracious and giving up a weekend every other month or so to provide a comprehensive RFA course for physicians from around the world. And you can't go without doing a little sightseeing. So the photo on the left is one of those iconic Rio views from the top of Corcovado Mountain. One of the really unique aspects of this course was the hands-on component, where we were able to observe and participate in a full day of radiofrequency ablation, which usually meant 6 to 8 patients. You can see from the photo that this is usually done in the OR, but for them, it's really more for ease of turnover and availability of staff and materials. These patients didn't receive any sedation or general anesthesia. They all tolerated the procedure extremely well. So seeing this and being able to experience it firsthand, I think really gave us the confidence to be able to bring RFA back home and offer it as an office-based procedure. And I think the biggest takeaway from watching and then starting to do these procedures independently, and something that we always emphasize to people interested in getting started, is that being facile with ultrasound first is really paramount. This comes into play in all aspects of the procedure, even from the first time you see the patient. Comfort with diagnostic ultrasound is important to be able to choose patients with benign appearing nodules that are appropriate and should respond well to ablation. And knowing the size, location, composition will all help you counsel the patient on what to expect. Being able to manipulate the ultrasound probe and the RFA electrode together to perform a complete ablation is actually more challenging than it might seem, especially when you think about the 3-dimensionality of a nodule. And actually one of the reps who's provided us with a lot of support as we've gotten started here recommends that interested providers try to do at least 50 FNAs before taking an RFA course. So that gives you some sense of sort of what the background expertise ideally should be. And then finally, being able to identify and avoid structures that we want to protect helps minimize the risk. These are structures that are typically not part of a radiology report, so we do have to be on the lookout when we're doing our initial or our pre-procedural ultrasound. We're always cautious to avoid treating in the tracheoesophageal groove to avoid any recurrent laryngeal nerve injury. And, there are more obvious structures that we're sort of used to seeing when we're doing thyroid ultrasound, like the trachea, the carotid, the jugular vein. But the vagus nerve, for example, is something we might not routinely look for on ultrasound. But when thinking about performing RFA, it really matters where this is located in the carotid sheath. So, for example, in the image here, this white arrow points to the vagus nerve, so you can see it's positioned laterally in the carotid sheath, and we may not be as nervous about, getting some heat at the most lateral aspect of the thyroid gland. But if the vagus nerve is located medial in the carotid sheath, we may think about trying to create some space between the thyroid gland or nodule with a little bit of local injection or hydrodissection prior to starting the RFA. And then, anterior jugular veins are so easy to miss. We are usually compressing them when we're doing our initial ultrasound, so it's good just to lighten the pressure for a moment and take note of where they are to avoid a potential hematoma. So now we'll get into some of the steps of the procedure. This part is probably the most important because it really determines your ability to keep the patient comfortable and do a complete and efficient ablation. Pain is the primary sort of what's considered side effect, if you will, of this procedure. And it's not uncommon for patients to report discomfort in strange places like the back, the chest, shoulders, teeth, jaw. In the picture on the right, you can see the planned entry points from which the local anesthetic and then ablation is going to be delivered. And this goes in 3 directions to cover the entire nodule. And this is sufficient for most nodules, but if you have a larger one, then you may need 2 or more entry points to cover the whole thing. So hopefully this video will play. That's good. So this video just shows lidocaine being delivered over the top of the thyroid capsule. That's where a lot of the sensory nerve endings are. And it also serves the dual purpose. You can I'll play it one more time, but serves the dual purpose of also creating some space between the nodule and the carotid artery, which is a phenomenon or a technique called hydrodissection. And then for the actual ablation, the technique used is called the moving shot technique. And this just refers to the fact that the tip of the needle is constantly moving as opposed to staying in a fixed location like what's done for, say, a liver or a kidney ablation. And the needle gets inserted through the isthmus of the thyroid gland. And this is for multiple reasons. It's so we can see the entire length of the electrode. It's so the tip is pointing away from the tracheoesophageal groove where we would expect to find the recurrent laryngeal nerve. And also because if the patient needs to swallow or they start talking during the procedure, having the electrode in the isthmus will stabilize the position. So we point the tip as far lateral and deep as we can, and then ablation sort of goes from the deep to the superficial aspect. And once we get to the most superficial aspect of the nodule, then we redirect the needle again to the deep and lateral aspect of the nodule. So this creates sort of a layered effect. And this looks a little bit funny. Hopefully this will play. Okay, there we go. So this is an actual ablation being performed, and credit goes to Dr. Orloff for this particular ablation. But what we're looking for is, as we draw the electrode back, is that white hyperechoic change that tells us the tissue has been treated, and then the electrode gets redirected to the next layer. I don't know if I don't think you can hear this very well on the audio, but sometimes there is a kind of a snap, crackle, pop sound that goes along with the bubbling, which can be disconcerting to some patients. So we have learned to disguise that with some relaxing spa music. So we'll let the video finish here. All right. And then once you have done a complete ablation in the transverse view that you have, you want to turn the ultrasound probe 90 degrees to look in the sagittal view to see where to go next. So I'll play this video here. Oh, maybe it won't play. There we go. So this is looking at the nodule in the sagittal view, and you can see the contrast here where the middle of the nodule is really nicely treated. It has a dark background and those bright or hyperechoic areas interspersed, while the superior and the inferior aspects still look like recognizable thyroid nodules. So we'll target those next. And then we'll also put the Doppler on intermittently just to make sure that we're taking care of any intranodular vessels that might later feed regrowth of the nodule. And then this video shows a sweep through the nodule once it's been completely ablated. So let's see, there we go. And the post-ablated appearance of the nodule is really heterogeneous. So to someone that's not aware that the patient's having RFA or maybe isn't familiar with the expected ultrasonographic changes from treatment, they would be understandably concerned for a malignancy because it now looks hypoechoic, irregular, has these bright echogenic areas that are easily interpreted as calcifications. So it's very important first to be certain that the nodule being treated is benign because it will not look that way afterward, and also to have a good dialogue with the referring physician who will be receiving the subsequent ultrasound reports that might sound scary, or in an ideal world to be able to do the surveillance ultrasounds yourself. Treatment response and success in RFA is measured in percent volume reduction from the baseline. And we tell patients the most rapid reduction usually occurs about 1 to 3 months post-procedure, and then continues at a slower rate of decline until around 12 months. So after the first month, the volume has already generally reduced by about 1/3 to 1/2, and then at 6 months, about 1/2 to 3/4. And then at 12 months, seeing ablation volumes that exceed 80 or 90% is often possible. And then around 12 months, there's usually a plateau, but data from patients who have been followed for 5+ years also show that this is often followed by sort of inexplicable but pretty consistent further reduction around the 3-year mark. In functional thyroid nodules, euthyroidism can be achieved in the majority of patients, and this means complete withdrawal from antithyroid medications in about half of patients, and then at least dose reductions in antithyroid medications possible in 3/4 of that remaining half that aren't completely taken off medication. There are some features that are more likely to predict success, and those with a smaller baseline volume are associated with better likelihood of complete cessation of antithyroid medications. And it's a little intuitive that greater ablation volumes and size reduction are also predictive of the ability to achieve euthyroidism. Because these nodules are hyperfunctional, and so they tend to be pretty vascular, regrowth is a little more likely, and so it is important to tell patients ahead of time that it could take more than one session to adequately and durably control their hormone levels. And finally, for the big nodules or the nodular conglomerates that are overactive, a combined technique can be pursued wherein a single RFA session is done up front and then combined with radioactive iodine, which is kind of nice because it allows for a lower dose of radioactive iodine to be used and often results in faster resolution of the hyperthyroidism. Because of the exceptional volume reduction seen after one treatment for the vast majority of these patients, yes, a single session with RFA will be enough to improve their symptoms and also result in a cosmetic outcome that they're happy with. The biggest caveat to this that's been identified, and it's somewhat intuitive, is that larger nodules tend to be more likely to require additional sessions. And it seems so far that the magic number may be around 20 milliliters for predicting a need for a second treatment. It makes sense. The larger the nodule is, the more difficult it is to ablate everything in one go. So there will be more opportunity for regrowth from untreated tumor and persistent blood supply. And we do consider additional treatments when patients have symptoms that haven't resolved, or they're not satisfied with the cosmetic outcome, or if we, say haven't achieved the 50% reduction in size that is considered to be a successful ablation, or if the nodule regrows over time. And the optimal timing of a repeat ablation is still under debate, but has suggested to be around a year or later, just to allow for complete involution of treated thyroid tissue from the first treatment to take place. And one of the most common questions from patients and providers is, what are the chances that my nodule will grow back? So long-term studies would suggest that depending on how regrowth is defined, it does happen anywhere between 5 and 25% of the time. And if it's going to happen, it can become apparent as early as 1 year post-treatment, but is more commonly seen around the 2 to 4 year mark. And it most often comes from marginal regrowth. So this means the undertreated area at the periphery of the nodule can fill in over time. And this is really where determining location plays a significant factor, because the inability to treat a certain area is going to increase the likelihood of regrowth. So if we look, for example, at this nodule in the ultrasound photo here, which occupies pretty much the entire right lobe. It's a great candidate because it's a primarily solid nodule. But this red triangle represents what is called the danger triangle, which is an area that we try not to ablate because of its proximity to the recurrent laryngeal nerve and our desire not to deliver any heat to that area. So this means that we know that we're going to leave a little bit of tissue there that in theory could regrow over time. And the same is true for nodules that are close to other important structures. So that's why we really emphasize the importance of paying close attention to the ultrasound and relevant anatomy when counseling patients on what to expect. Radiofrequency ablation, thankfully, is a very safe procedure, and there are a number of studies, including large numbers of patients, that have established an overall complication rate of around 2 to 3%. So this particular table comes from a multi-center study that includes about 1,500 patients with benign nodules. And because of the very targeted nature of the treatment, the incidence of recurrent laryngeal nerve or vagal injury is quite low. It's just around 1%. And this is, I should mention, another reason to have patients awake during the procedure. So you can intermittently ask questions and get feedback in real time about voice changes and act on them quickly if they do happen. Nodule rupture is uncommon. It's thought to be the result of delayed bleeding and subsequent tearing through a weak point in the capsule of the nodule. Thankfully, most of the time it can just be treated with antibiotics and compression. One of the real advantages of RFA is the ability to preserve normal thyroid parenchyma. So this results in a drastically lower risk of hypothyroidism post-op compared with surgery. You can see here that out of 1,500 patients, there was only one person that developed hypothyroidism in the follow-up period. Other types of nerve injury do happen, but are pretty rare. So this can include injury to the brachial plexus or the sympathetic chain. And then the more minor complications and side effects, for the most part, can really be avoided just by seeing the tip of the needle the entire time that you're working and avoiding, large blood vessels, staying away from the skin, not getting too much heat close to the trachea or the thyroid cartilage so the patient doesn't cough while the procedure is being performed. And this particular study directly compared RFA with surgery for 400 patients with benign nodules. And this again just shows the safety profile and potential benefits over surgery, especially as they pertain to nerve protection and also hypoparathyroidism, which is essentially non-existent for radiofrequency ablation. So a bit about our experience to date. As of this Wednesday, actually, as of yesterday, we treated 10 patients and we have post-treatment ultrasound data on 6 of those. And so far the results have been really excellent, and we've seen anywhere from 26 to more than 50% volume reduction after just 1 month. And 58% reduction for that one patient that does have a 6-month post-procedure ultrasound. And this particular patient had an almost 8-centimeter thyroid nodule, and after only 4 weeks had a 42% reduction in volume. And I know that we probably have some pointers to take from Dr. Most and Dr. Pepper about staging before and after photos. The change is still very obvious, and she was very happy. So we're certainly still early in the process, but hope to have more success stories and longer follow-up to share with you next time. This is just a fun cartoon. I think in the life cycle, of any new procedure, there's this adoption curve, and the true test always is, can whatever it is cross the chasm? And I think when it comes to RFA, there's been this very long, steady warm up to the edge, and now it feels like we've taken a running jump and flying leap over to the other side. And I think that in the next 5 to 10 years, we'll really see that this changes the way that we think about and manage benign thyroid disease, and probably some primary malignancies as well. So I thank you all for listening in, and I think some things have been popping up in the chat, so I'm gonna try and look at those and answer them if I can. Let's see. Okay, so I will answer, I think it is Dr. Chang's question. So it doesn't matter that it's impossible to know for sure that you ablated absolutely 100% of the thyroid nodule. And effectively, yes, it doesn't matter to know that you haven't ablated 100%, because just in taking care of most of the blood supply and the majority of the thyroid parenchyma, the stuff that's sort of in between will be no longer viable and will also undergo involution. So, although there's a very systematic way to do this, it's not necessary to, ablate every sort of square millimeter or centimeter of tissue. Let's see, and how do you know that you missed a malignancy in the wall of the nodule? Can you use RF for cysts? So I think the missing a malignancy question is one of the biggest ones in radiofrequency ablation. For patients considering this, we ask that they either have 2 benign biopsies or that they have 1 benign biopsy and a classically benign ultrasonographic appearance. And I think the difficulty with that is that a lot of these patients have 4+ centimeter nodules, and we know that over about 4 centimeters, the diagnostic accuracy of a fine needle biopsy as being representative of the whole nodule decreases somewhat. So I think that's why it's at least somewhat reassuring to see that there's good data also in primary malignancy. And so in theory, for those patients that have a 3 or 5 millimeter focus, say of papillary thyroid carcinoma, in their thyroid nodule, that this could also be effective for that. And then for cysts, RF is not as good for cysts. We typically tend to favor ethanol ablation for cysts, but a lot of benign nodules have a combined component, so you can certainly do both on the same nodule at the same time. And then that's another good question. So RFA and subsequent thyroidectomy. It is not done often, and so there is not great data on it, but the few people that have done it have said that it really actually doesn't affect their tissue planes at all. There may be some sort of minimal scarring between the strap musculature and the thyroid gland, but once they've gotten to the deep tissues, sort of where you'd be concerned for recurrent laryngeal nerve or even parathyroid glands, that because all of the ablation has been very targeted within the thyroid nodule, that it doesn't really significantly increase the technical difficulty of doing a thyroidectomy. Let's see, Anilesh's question. Is there a role for using RFA to shrink a nodule prior to surgical resection to make the surgery easier? That's a great question. And yes, it has certainly been done either to shrink a nodule to make surgery easier, or as 2 or 3 subsequent procedures to treat, say, a substernal goiter or substernal nodule. So there are certainly patients that have maybe a mediastinal component to their nodule, and so you can treat as much of the nodule as you're able to above the level of the clavicle. In theory, over time, when that tissue involutes, it should sort of pull up the tissue that's sitting in the mediastinum, which you could then either re-ablate or operate on. Dr. Sung, do the ultrasound characteristics after RFA change over time to look more like the original benign nodule? It's a good question. So the treated areas will look as they did initially post-procedure, essentially until those areas have involuted. So when these patients, for example, come back for their post-procedure ultrasound, you can tell which part of the nodule has been ablated and which part still looks like sort of normal thyroid nodule. So say, 12 months down the line or 24 months down the line, those parts that have been treated should all have, died and been reabsorbed. And at that point, it should more closely resemble a normal thyroid nodule. But for the first year, while that involution process is still happening, any of the treated areas will look, they do look kind of scary. They look hypoechoic and have these bright spots that are easily interpreted as calcifications. Okay, and Ksenia, currently it's a novel technique performed by ENTs with time. Would radiologists or ultrasound technicians be able to perform this technique? That's also a great question. So the Korean groups that have really been the pioneers in this, for the most part, are radiologists. And this is sort of where this procedure originated, was in radiology. And then across the world, it has been sort of adopted by otolaryngologists, by general surgeons. There's even a new sort of phenomenon of interventional endocrinology that is being born in part to incorporate this. So, there are a number of providers who, for whom this sort of falls within their wheelhouse and might be interested in performing this. In terms of an ultrasound technician, I think that's an interesting question, because we know that a lot of technicians are very skilled in identifying structures and just have a lot of experience in obtaining images and interpreting images even. I think it would be, I think we have a longer way to go, and I don't know how comfortable they would be with the interventional part of it. Do you foresee RFA extending to other indications like multinodular goiter or Graves' disease? I think yes and no. I think for multinodular goiter, there are certainly patients who have a dominant nodule that's causing a compressive or a symptomatic concern. So even if other nodules exist, so long as you're reasonably confident the patient doesn't have a malignancy that would require a surgery, then it's certainly possible to treat the dominant nodule, and even multiple nodules can be treated in the same session. The only thing that we're a little careful about is aggressively treating bilateral nodules, and that's in large part because in the first 1 to 3 days after surgery, the nodule size is going to swell and get quite a bit bigger, and so we don't want to sort of incite any airway compromise that might happen as a result of doing really kind of big or aggressive bilateral treatments. And I think for Graves' disease, it's a little bit of it would be tough to ablate enough tissue to achieve resolution of hyperthyroidism without tipping someone over into hypothyroidism. And that has been one of the primary draws of radiofrequency ablation, is to be able to, achieve hormonal balance. And so I think, relative to surgery or relative to radioactive iodine, RFA I think is unlikely to also be able to sort of achieve the sweet spot of euthyroidism, and would either require complete ablation to resolve the hyperthyroidism, or might require multiple treatments, which may then result in ultimate hypothyroidism. Okay. I am happy to take any other questions if there are any. Thanks, Dr. Sajati. Yes, and that's true. Chris Graylap gets a lot of credit for this figure, which some of you may have seen. We had a webinar a couple weeks ago now that had actually a few hundred registrants, which was really exciting. So if you are inclined to get some more specifics about radiofrequency ablation, I think it's up on our website, and I think Olya had also helped us post it on the Stanford OH&S Instagram account. All right. Okay, thanks everyone.